German says, we really need a low-cost, important intervention for prematurity. I'm just going to briefly take a chance to summarize the trial, talk about the epidemiology of prematurity, talk about why it's been so difficult to solve, talk about the fact that this really is probably not one disease, but many diseases, talk about why BV may play an important role, and although there have been many trials about BV in pregnancy, why in fact clindamycin may be a unique gem in terms of treating it, and compare it to metronidazole, which has been disproven to be effective in preventing preterm birth. And then finally share with you some of the preliminary data of the trial that's been conducted here in Belgium. So just to echo with what Dr. German had said, preterm birth remains the leading cause of neonatal mortality and long-term pediatric neurological sequelae. One of the things that we forget about is of those children who survive, is they in fact have different health and neurological outcomes all the way measured throughout the course of their life. So these studies have been done time and time again. India as a country, both because of its high preterm birth rate at 13%, as well as its relatively large number of births, contributes about 1 in every 5 preterm births that occurs on the planet. About 3.5 million preterm births, and a number of about 309,000 deaths result of preterm birth, resulting in families not being complete or whole. And unfortunately, there really is not a cost-effective strategy. You've heard about steroids, which have proven beneficial in other parts, but the reality is that preterm birth rates have remained stable, if not gone up, in both the developed and developing world. I won't echo this other than to say again, is the US rate looks unfortunately a lot like the India rate. The two countries are indistinguishable, and despite the fact that we spend literally billions upon billions of dollars on this problem, we are no better at resolving this problem than India has been. So this, although it's an unmet medical need in India, it's really an unmet medical need across the world. There's been some gains across the world, and we've been involved in some of these studies in the US. People have looked at progesterone, cervical cerclage. Pessary has gained a lot of interest around the world. But the challenge is identifying women who uniquely benefit from these therapies is relatively small. And in fact, if you look at the effect, and you can argue whether these treatments are effective at all, it only is marginally effective. So if we're going to get a meaningful strategy, we need to be involved with a large group of women with a treatment that's highly effective. And again, with the exception of steroids, there's been little progress that's been made in preterm birth in the last 40 years. Almost all the success that we've seen has been with our neonatal colleagues. So if you look across the rates where we've seen improved survival, almost all of this is the result of improved postnatal care, kangaroo care, as well as other things. And these resources are expensive and problematic to meet. So this is probably the most important slide in the whole bit. And one of the challenges is when we've looked at it from a research standpoint, we think of preterm birth as really being one disease entity. And the reality is that preterm birth is really caused by 4 separate different groups of problems. So we have inflammation or infection, which is probably the largest cause, or about 40 to 50. But if you look here, this is the one part that we're going to talk about. And again, probably the largest cause of preterm birth around the world is due to inflammation. There have been some important growths in terms of inflammation and understanding of inflammation, and I just show you this baby's head here. And if you look here, the cervix is very, very long. We actually know that in many women, in fact, what starts months before, in fact, probably between 16 and 20 weeks, is the cervix begins to open up from the top, forming this sort of Y shape here. Eventually it opens all the way and then sort of rounds up here. What this does is it allows for inflammation and particularly infection with common bacteria that lie within the vagina to ascend and infect the choreo and the amnion that surround the baby. This is a more recent finding, and this is in fact an ultrasound picture not just of a woman whose cervix has shortened, but in fact has developed what we now call sludge. When we test this sludge, what it actually is an infection. So when we have biopsied this with amniocentesis, in fact we see that these women are infected, In fact, we know that women who have that finding on ultrasound are much, much more likely to deliver quicker, even women with short cervix. So we know inflammation and cervical changes are important causes of the preterm birth story. This is a sort of famous picture from my good friend Jay Imes from OSU, who first looked at cervical length. And what he found, again, is what we had not thought, which is, in fact, preterm birth is a process that happens in the first half of pregnancy in many women, not in the second half. And when we measure the cervical length, the longer the cervical length, the less likely you were to deliver premature, versus if you had a very short cervical length, you in fact would go on to deliver relatively quickly. And again, sludge or the presence of infection often is there weeks before the baby goes on to deliver. So back in the 90s, people became aware of the fact that BV is an important contributor. So we had known for many years that women of lower socioeconomic status, African American women, were much more likely to deliver earlier than other cohorts. And in fact, what we've learned since then is, in fact, that it plays probably a permissive role. So BV is not an infection, it's an inflammation. So again, the role of inflammation is important. It's the absence of normal lactobacillus. But along with that is allowing other organisms that we now know are important in preterm birth to flourish, particularly M. hominis, which if you look at amnio specimens, looking at modern technologies of looking at DNA for bacteria, are present in somewhere to about a third to a half of preterm birth. So mycoplasma and rheoplasm particularly have been implicated in the role of preterm birth. And in fact, BV makes them more available and also creates inflammation in the vagina that probably plays a role in the cervix developing some of its key changes. So back in the 90s, there became a lot of interest in the idea of screening women for BV, and could we prevent preterm birth by giving them antibiotics that we know treat preterm birth. Particularly, there was a lot of interest in metronidazole. So metronidazole is an old drug, very well established safety record. The problem is in fact, if anything, it made things worse. And in fact, if used as an antibiotic alone, it increased the rate of preterm birth, not decreased preterm birth. When you looked at the category of macrolides, of which clindamycin is one, in fact, what you saw was a very different story. You saw that the preterm birth rate was decreased by about a quarter to about a third when you look at clindamycin alone. And when you looked at the data, most of this actually stemmed from a single trial in the United Kingdom of 400 women, an important number to remember compared to the trial that we've just completed here. So based upon this information, we had some conversations and thought there were some really key things about clindamycin. Again, it's a macrolide antibiotic. It works through a different mechanism than metronidazole. It works through the RNA mechanism. And probably most importantly, it's bacteriostatic, meaning it stops the bacteria from developing. It doesn't cause the cells to actively lyse, causing a local inflammatory response. It, in fact, may have some anti-inflammatory approaches as well. It helps the host response. And then again, as I pointed out earlier, M. hominis, which is a bacteria that is supposed to play an important role in preterm birth, it's uniquely effective. Comparing this to metronidazole, once again, it works through a different action. It has relatively poor efficacy against M. hominis, and it's bactericidal, which may cause an inflammatory response. So based upon this, we went ahead and did a small hospital study that is in the process of being published. We looked at 200 women, and in fact, what we found is that we saw a 65% reduction in the rate of preterm birth. Huge, huge differences. The average cost per woman, under $1. So huge opportunity, potentially. So based upon that information, we were able to secure funding from the Thrasher Group. Very much would like to appreciate and thank them publicly, with the principal idea of launching a trial where we screened women between the gestational ages of 13 to 20 weeks. If we had ultrasound, we took that information. If not, we went ahead and simply randomized them with the idea of it being a pragmatic trial. Rather than fancy screening tests, we just simply used colorimetric paper, literally less than a penny a woman, and randomized women with oral clindamycin 1-to-1. Dr. Ganasheri has handmade most of my placebos in a heroic effort, to say the least. And then again, using the infrastructure that you've heard so much about, the registry that provides such wonderful data, that we had the opportunity to go ahead and move this forward. So this was early in the trial. I think I was a little thinner back then. But we have launched now a little over 3 years ago. And on February 27th, we had our last delivery of our 1,728 patient. So the trial is now completed, and I wish we had scheduled for about another 7 weeks from now, and I could give you the data. Unfortunately, all I can do is give you some preliminary information. Since we're looking at the 6-week outcome, we don't have those. Interestingly enough, if you went out into the community, almost 1 in 4 women had BV as developed by an elevated pH. The women who participated were incredible. They had 94%, 100% compliance, meaning they took every pill. Absolutely amazing. And in terms of outcomes, again, 99.7% of them, 42-day outcomes. We're still waiting for patients to reach this mark, but we have 96%. And in terms of side effects, what I can say is we only had 12 women out of the entire cohort, in fact, who went to visit a hospital or doctor for a reason that was not intended or related to the delivery process. So again, incredible numbers, incredible follow-up, and really an attribute to the group who is dedicated to doing this kind of work here. So again, we are almost at the terminus of this. I wish again we were here a few months from now where I could share with you the 42-day outcome. The analysis will be following, but this will be the largest trial of clindamycin to prevent preterm birth that's ever been recorded to date. So a real accomplishment for the team that's in the room, and again, an opportunity for me to say thank you.
Study that suggests that a cut point of being over 75 gives you a better outcome.